what we focus on is doing a more in-depth assessment on how your visual system is working together. So we have no financial disclosures. So just a very brief overview is we'll focus on what are some of the visual symptoms that you may present with post ABI. I want to give a brief insight into our assessment, so how it's different from our other eye care providers, which also play a key role, but how our assessment can be somewhat different. What are some of the management options that we may discuss or offer? And then we'll go into visual field deficits, specifically for patients that may have had a stroke. So in terms of visual sequelae, so the impact from a global perspective, what's the impact on the visual system? And so these are the different areas that can be impacted post-TBI. So the areas that we tend to focus on are your eye focusing, specifically your accommodative system, which is your how clear are the objects that I'm looking at. And usually this is roughly impacted in folks less than 45 years of age. Just because naturally what happens is as we get wiser, the lens in our system, the crystalline lens in our eye tends to change, so it's not as flexible. We look at eye teaming, which is how well do my eyes work together. We look at eye tracking, so this is how well can I fixate, how well can my eyes move from side to side, and how well can my eyes follow something that's moving in space. Visual field deficits, so we'll have patients say, I'm missing half my visual field, or I'm missing a quarter of my visual field, and Dr. Lin will go much more into that near the end of the presentation. Your visual and your balance system are very well integrated, and so sometimes what might happen is if you have a deficit in one system, the other system's trying to compensate, but what ends up happening is you might have symptoms of unsteadiness, dizziness, balance issues, or balance difficulties. Visual information processing deficits. So patients will come in and say, hey, I'm not able to multitask, or I'm not able to attend to things. You know, I'll be opening up the fridge door looking for the milk and the milk's right in front of me, but I'm not able to see it. So we'll go ahead and evaluate those subsystems as well. So this is just a very short list of the symptoms that our patients may present with. So it's not all encompassing because, you know, and I'll talk more about some of the other symptoms that patients may come in with, but it can be things like skipping lines or having to reread when reading, difficulty with scanning, headaches with near work, computer work, asthenopia, which is fatigue, vision coming in and out of focus, double vision. I've had patients say, hey, the words are swimming on the page, or they feel like they're coming in and out or pulsating on the page, dry eye or just burning sensation of their eyes. Flashes and floaters, light sensitivity is a big one. We're going to talk more about light sensitivity in the next few slides. I'll have patients saying reading or scanning gives them nausea or dizziness, vertigo, loss of balance, motion sensitivity, difficulty in busy environments. So they're not able to go to Target or a Walmart or a grocery store. So they avoid those environments. Scrolling on the phone or on a page, you know, our reality is we use devices, right? And so they have difficulty with using devices. If you have visual field deficits, you may bump into things on one side. You tend to prefer one side, or you might have shift in your gait. Difficulty with reading, decreased attention, confusion, behavioral changes. And this doesn't include, like we already mentioned, is saying things like, hey, my memory's not great. I'm having difficulty remembering things, or my processing speed isn't what it used to be. So these are additional frustrations or concerns that our patients come in with. Any questions? Feedback? Perfect. So let's go ahead. I don't know if I don't want to miss anything in the chat. That's the only thing.
Yeah.
No? Okay.
So yeah,
perfect.
No, you're good.
Thank you. So in terms of, so a lot of times folks will come in and say, hey, I've seen my eye care provider and they told me everything is normal or everything is the way it should be. And I said, that's great. I'm really glad that you saw your regular eye care provider because they're looking at structure. And really structure is important to look at as well. Once the structural components of your visual system have been looked at, we look at function. And sometimes we've had patients where they haven't seen an eye care provider, so then we'll look both at structure as well as function. So I do want to talk about some symptom surveys that I think can be helpful. So two things that we look at is there's two symptom surveys. One is the brain injury vision symptom survey on the left, And these have symptoms, specifically visual symptoms, that tend to occur after patients have had a traumatic brain injury. And so we'll do this survey in our clinic as a baseline. So it just provides insight into what our patients are experiencing. And if they're doing rehabilitation, whether in our clinic or in other clinics, it's a way to track how their visual performance or visual system is responding to the treatments. The next survey we have is the Vision Quality of Life with Time survey. So that's the one on the right. This one is a newer survey that we've implemented. And so what it looks at is how are the activities of daily living or the things that you enjoy doing, how long are you able to do them before visual symptoms or other symptoms may occur? And so I like to, again, have my patients do this as a baseline before we start therapy, because the biggest thing is we talk about therapy, which obviously we support or we're big proponents of, but it has to translate to your activities of daily living. If it's not improving your ADLs, it's not having the impact that we want. So I really like this as a baseline. And sometimes when we start a therapy program, a lot of our patients will be, my symptoms come in within 0 to 15 minutes, right? Within 5 minutes, I can't read, or I'm not able to study if they're in school, or not able to work on a computer. We'll do therapy and then we'll bring out the survey post-therapy and we'll say, hey, oh my God, you can do it for 30 to 45 minutes. Like, let's celebrate, right? This is awesome. So it's just really nice to show the changes that are being made and to, be a cheerleader and celebrate with our patient. So this pyramid kind of goes into what exactly is a comprehensive neurooptometric evaluation. So we'll start with the base here. And this is oftentimes done with our other colleagues who are eye care providers, is just making sure that my patient has the right spectacle glasses, right prescription, and their eyes are healthy. So really from a structural perspective, are things where they should be, and are they normal? Once that has been confirmed, we then start going into the looking at visual function. So looking at how are your eyes working together as a team, how are they focusing, and how are they tracking. Once that's been evaluated, we then look at visual fields. We spend a lot more time looking at the integrity of your visual field, especially in our patients that have had some form of like a stroke or whatnot. Then we look at visual perception. So that's looking at, once I look at the information, how is my brain processing that information and how is it integrating it with other systems like your eye-hand coordination, vision and listening, or vision and auditory. We also look at vision and vestibular. Again, those two systems are very much together. They work in tandem. And so we'll do some screeners to see how are those two systems working together. Treatment and management. So this is when we then talk about, hey, these are our findings. This is what we're recommending. It could be anything from changing your glasses prescription, maybe giving you some tints in your lenses if you're really light sensitive, recommending vision rehabilitation. And then the last part is referrals. So with referrals, sometimes we'll work with patients where they're not sleeping all night, right? They'll come to us and they're like, hey, I don't sleep until 2 a.m. I'm waking up every 20 minutes and then I'm waking up, sleeping in through the day. My sleep schedule's a wackadoo. So how, and I'll say, hey, I think you need vision therapy, but let's refer you to a sleep specialist. Or they'll say, hey, my neck is really impacting me. And neck and vision is also really much linked together. And so sometimes I'll say, hey, I think you need to see a cervical therapist first. Let's work on your neck musculature and then come back and see me. So again, we work very much closely with other providers to make sure our patients are receiving optimal treatment. So this is when, hey, how can I find someone who actually understands what I'm going through from an eye care perspective? So we have 3 links here, and we can always share this with your team. I can email you the links.
Yes.
And then you can always share this with anyone who's interested. These are 3 different resources where you're able to find someone who specializes in working with patients post ABI.
Mm-hmm.
So we'll go into a brief overview over management. So when you come in and see us, these are the things that we're thinking of as we're doing our assessment of what we can do to help you. So one is obviously making sure you're wearing the optimal glasses prescription. I'll have patients coming in wearing progressives or no line bifocal lenses. So once you hit the age of 40, where our wiseness really kicks in, sometimes you need both a distance prescription as well as a reading prescription. And a lot of times this no line bifocal can exacerbate symptoms of dizziness or feeling unbalanced, especially if they're doing other therapies like PT or whatnot. So a lot of times what we'll do is we'll have this discussion with our patients and sometimes remove them from those glasses temporarily. So then they're just doing a single vision, one pair for reading, one pair for distance. We just had a patient in clinic this week who said, because we switched her out of those glasses, the no line bifocal, her physical therapy is going much better because she's not as disoriented through that no line bifocal. So that's a discussion that we'll have with you to see if that's something we need to do. Obviously, making sure that your eyes are healthy. If they're not healthy, if we can't manage it, we'll refer it to some of our colleagues. We'll look to see, hey, can we do something special with your lenses, whether it's adding prisms, filters, tints, and we'll talk more about tints in the next few slides. Sometimes we do something called binasal occlusion. Some of you may have had this where we put a little bit of tape on the inside of your glasses. Again, we do that only based on what our patient's concerns are and if we think they'd be a good candidate for that. Neuro rehab therapy, is that a viable treatment option for you? And then obviously, like I mentioned, do we need to refer you to someone else or loop in other healthcare providers, again, to optimize your treatment and recovery? I do want to talk a little bit about light sensitivity because this tends to come up a lot with our patients. So immediately after injury, patients will say, I was super light sensitive. And so what ends up happening is, and they're light sensitive both indoors and outdoors. Outdoors, we say, wear sunglasses, get dark sunglasses, polarized lenses, the works, right? Outdoors, totally fine. But what ends up happening is when they're light sensitive indoors, they end up wearing sunglasses indoors or wearing a hat, turning down the lights completely, understandably so. If it's irritating you, you're going to do something to minimize that irritation. But what ends up happening is then our visual system is not able to adapt to normal lighting conditions. And so I'll have patients coming in, it's been years out and they're still wearing dark sunglasses, they have headphones on and a hat, and they're always in complete darkness. And so we actually educate our patient is that you actually want to expose yourself a little bit to normal lighting conditions indoors. And I'll have patients keep like a light diary, right? So try to give yourself normal lighting for 2 minutes and see how you feel. If we don't have symptoms triggered, so I've had patients say they had really bad migraines or dizziness, eye pain. If you don't have exasperated symptom provocation, then the next day do it again. Do it again. And then slowly start increasing the time you're exposing yourself to normal lighting conditions. And let's slowly habituate you to being able to tolerate indoor lighting. So usually patients will be keeping like a light diary. And again, it's very much based on what you're able to tolerate. Now, if we have patients where they're not able to tolerate any form of indoor lighting, we'll go ahead and then do tinted lenses. We tend to be conservative with tinted lenses because, again, we do want you to adapt to normal lighting conditions. And so if we are to do tinted lenses, we'll go ahead. We have a whole plethora of tinted samples in our clinic. These are the colors that most often patients like. And then what we do is we actually prescribe the lightest tint color that you find the most comfortable. And then as you're getting better through your therapies, we'll actually titrate or decrease that tint amount over time. The other thing we like to talk to our patients about, again, we all have devices, and a lot of times we'll see patients coming in where they either have done white on black, which is totally fine, so white font on black, or they've completely decreased their brightness level. So people will look at their phone and say, hey, is your phone even on right now? Because I don't see anything. And so we will go sit with our patients and actually go through how you can change the background of your phone to make it into a color that's more comfortable for you. So we won't go through all of these right now, but I can share these cheat codes to your team here, and they can always share these with you. But this kind of goes into how to improve how to improve being able to look at your phone based on iPhones. I'm an Android gal, so I had to put Android in there, but we have them for both.
Nice.
And it's really nice to see what the phones have built in, because essentially they want folks to be comfortable when using them because we are on them so much. So there's different things that you can play around with, such as like decreasing motion on your screen. You can magnify, you can make your font size bigger and thicker. So there's different accommodations already built in. Briefly about vision rehabilitation. So a lot of times when folks come in to see us, they've already been doing several different therapies. So they already know sort of how the therapy program works. Ours is very similar. The difference is that obviously our focus is on the visual system, but also the integration of the visual system with balance and movement and your vestibular system. And so I always tell my patients, it's not like a cookie cutter approach. These eye exercises are very much customized to every single patient based on what we find during our assessments, but also what our patients' goals are, right? And so we also need to see, like, what, based on my patient goals, is this therapy program going to be appropriate for you? And so we have that discussion prior to starting therapy, and we have that discussion almost every single session. So in terms of vision rehabilitation, patients come in for a weekly in-office visit. The visits are around 45 minutes to an hour. There's also home exercises. We are always doing reassessments. So every session, we're talking to our patients, like, how are you feeling? How are things going? How are other therapies? Just getting an update on how things are progressing. And we always want to recheck. We usually recheck every 5 to 6 sessions on objective metrics. Objectively, are things getting better? But also subjectively, are things getting better? Because again, yes, we're doing something in a therapy room, but we need to make sure that it's actually translating to your day-to-day activities. And then I can't stress this enough, co-management. I will say everyone here is very familiar with this. There is a whole management team that works together. So we ourselves, we try to be as plugged in as we can. So going to support groups, talking to other providers, because again, so I was spoiled when I was in the Bay Area. I was working at a hospital setting where we had everything under one roof. So it's like, hey, I think you need physical therapy for balance. I'm going to click a button in my computer and you're going to get referred there. Unfortunately, that's not the case what I'm seeing in Orange County. Everything is very disjointed. Some providers are cash pay, some are insurance, some are not. So
Silos, we call
it's
silence.
And me as a healthcare provider, I struggle to manage or triage the healthcare system. So we try to be plugged in with as many providers as we can. So again, we can provide resources or at least referrals for our patients.
Perfect.
All right.
Likewise.
Yes.
Right. Perfect.
Hi, everyone. I'm Dr. Rachelle Lynn, and I'm just going to jump in here and talk a little bit about strokes because I wasn't sure how much of the breakdown of the group is kind of traumatic brain injury versus stroke related.
Let's get a feel here. So of the folks stroke involvement, either hand raise or thumbs up or
In the chat.
In the chat. We have one, we have Eddie, we have John, and
yeah.
Okay, yeah. So
A few.
Yeah, you have a few. Yeah.
Yeah.
Okay. So some of these overlap. Some of these symptoms can also happen with traumatic brain injury, and sometimes they're now. And some of these are much more common with strokes, but these are related to vision. So even though we might check your eyeballs and your eyeballs look 100% healthy, patients are still having difficulty with recognition or vision in some way, and it could be because of that brain injury itself. So with strokes, there can be disorders of higher cortical function. Some of those include disorders of recognition, such as object agnosia. So you might know that this is a cell phone, but you might not be able to verbalize what it is, or in an eye exam, we might notice that the patient can see the letters, but they can't say what the letters are. So we'll find a different way to check their vision. And then prosopagnosia is specifically for face blindness. So you can see someone's face perfectly fine, but it's like you can't put the pieces together and you can't recognize that face. And people with really severe versions of this face blindness sometimes even look at themselves in the mirror in the morning and get scared because they're like, I can't even recognize my own face. And this can be really debilitating and really sad, especially if you feel like you can't even recognize your family's and your loved ones' faces. I see a hand up. Anne, did you have a?
Yes, I have apologized to people and let them know I had brain injury, so I do not have facial recognition. So
Right.
I didn't recognize them. Yeah.
Right.
So,
And yeah. Yeah, and I've had even friends of mine who will tell me they have prosopagnosia, and they just say, "Hey, don't be offended. Just make sure you introduce yourself when you show up in a room." And I'm like, "Sure, absolutely, of course." Um, there's also disorders of awareness of vision or visual loss. So there's kind of two things here. If you have a field loss, a side vision loss that could be associated with your optic nerve or from the brain injury itself, um, sometimes you're very aware of it. You're like, like I know I can't see things on that right side. It's very annoying to me. I know I have to scan more to that side. And then there's a separate condition where it's just awareness of the vision. If you're not even aware of that side of your field. So patients who have that problem, they might say, "Oh, I'll do my makeup. I think I've done both sides of my face, and I'll realize I forgot half of my face." Or I'll put one side of my jacket on and forget to put on the other side. Or I'll look at my plate of food and I'll think I have eaten the entire plate of food and I'll only have eaten one side. So you just forget to attend to one side. So that's called hemispatial neglect. And on here, there's a picture of a clock that one of my patients drew. And I told her, draw a clock, put in the numbers, and you can see that she put all the numbers on the right side, but forgot that numbers also go on the left side. And then on the right side there's a different patient. He had a milder version of this hemispatial neglect. He didn't even realize that he had it. But when we asked him to draw this cat that has the two tails, he did pretty well with the face, but then when he got down to the little detailed legs and the tail, he forgot one side of the tail. So he had a milder version of this hemispatial neglect that we were able to identify. And sometimes we'll be talking with family members or we'll be talking with caretakers, and they'll be like, "Well, it's so weird. Sometimes it seems like the person with the eye condition, like they'll be able to see perfectly fine, and sometimes it's like something's right in front of them, and they don't see it right in front of them. Why is that happening?" And if we can at least put a name to it and explain why, we can move forward. Field loss, these are just examples of what those might look like. So hemianopias are when patients have loss of one side of the field. So it'll be the right side of the right and the left side. Sorry, the right side of the right and the left eye, or the left side of both eyes. In this case, you can see here that a normal visual field would be that entire gray portion there, that little gray ovular side shape. But then you can see that on this side, the patient's missing a little field and missing a little field. On the right side, you see this image where this patient is missing this like quadrant. So this would be a quadrantenopsia, where they're missing that left lower side of both eyes. And sometimes patients don't even realize that it's in both eyes. They just think it's that one eye. So what can we do for patients with this? One of the things we can do is scanning therapy, but another thing we can add on to that is these special prism glasses that are called Peli lenses, and they are specifically designed for visual field expansion for patients with these hemianopias or quadrantinopias. It's a little bit hard to see on there, but this pair of glasses, this is a patient of ours, and she has this little Peli stick-on prism that is on the bottom part of her right lens. And that's because she has a little quadrant there where it's harder for her to see on that side. So the prism allows her to detect things on that bottom left side or on that bottom right side that she wouldn't notice immediately. And in her case, she wouldn't even notice it until it's almost right in front of her face. But with these glasses on, she can notice it even when it's a little bit past her shoulder. So I tell her that's great. It's not like it's giving all of your vision back, right? The reasonable expectation is it gives you some vision back. It allows you to notice things there. But what I worry about is if you're walking around in a busy area and you're going to bump into something or fall, we don't want that to happen. We don't want you to have another head injury or any other injury. But if you can at least notice that something's there on that side, you're not going to run into it. And then she also has here, we talked about a little bit earlier, Dr. Bansal, where'd my mouse go? There you go. You can see that we put a little bit of Scotch tape on the part of the glasses that are closer to the nose, that's because she also has that visual motion sensitivity. So when she goes to a busy environment like a Walmart or to go pick up her kids from school and there's just so much happening, she feels really disoriented. And with these glasses on, with that little bit of tape, it doesn't cut out the visual field, but it just helps calm the vision a little bit more so she can focus on what she's trying to see. Yeah.
I mean, that's fantastic. So I really just going in that, right? Because I've seen some people
Yeah.
like they have the little scotch tape
Yeah.
there, or even this like nail polish.
Yeah, nail
Yeah.
polish.
that,
Yeah.
Is you describe emotion sensitivity.
Yeah.
And so for the motion sensitivity, because you know that's come up quite a bit, is some people have that motion sensitivity, and so like so if you're having something like that's causing like dizziness or nausea, what seems to be like the underlying thing with the motion sensitivity that results in some of those symptoms?
So there's not much research behind it, but what the premise is that your nasal visual field is an overlapping visual field, and so it can cause a lot of visual noise and confusion. And so it's really hard for patients to filter what's important and what's not important. And so what ends up happening, it's almost like a lot of our patients, when we see them, they're already in fight and flight mode. And so a lot of times you're supposed to be able to, if I'm talking to you,
Yeah.
I'm talking to Daniel, and while I'm aware of my periphery, my focus is on Daniel. So I should still be able to kind of be aware, but ignore what's going on here while focusing on him. But what ends up happening is, because I think you're in fight and flight mode, you're focused on everything. Like, I am talking to you, but hey, I'm going to focus on you. I'm going to focus on you. I'm going to think what's going on here. And so you get overwhelmed. You don't know how to filter things. And when you're in a busy environment where you're at a Walmart or a Target or a grocery store, there is a lot going on. You have people in your periphery, you have stuff on the shelves, you have announcements going over the intercom. And so sometimes what we end up doing is, by putting this binasal occlusion, it's a very thin amount of occlusion. And side note, I don't recommend that you just try it yourself. Come see us.
Yeah.
You can.
Don't do this at home.
I have to put my disclaimer on there. If you do it, that's fine, but we don't want to know. But no, so what ends up happening is you put a little bit of tape in the nasal portion of your glasses, and essentially cuts down that overlapping visual field or that noise, and it's supposed to help you be able to process that visual information. It makes it a little easier to process that visual information. So what ends up happening is, when we do try it with our patients, I don't give them the background behind it, because I don't want to have a bias of like, this is how you should respond. But I always tell my patients, you're going to give me 3 responses. And obviously we're in an exam room where it's like a very artificial situation. But the 3 responses are: I hate this. You better take this off my glasses right now. I don't really notice a difference. Or, huh. And I'll talk about the huh after. So the ones that say, oh my God, I hate this, take it off. Fine. No harm done. We did a little bit of scotch tape. You don't like it. We're going to take it off. The other ones are, I don't notice it. I don't really notice a difference. So I'm like, great, keep it on your glasses. Go home and actually try it with your normal activities. Again, you're in an exam room, very artificial, but go home and try it. If you like it or you notice a difference, keep it on. And a lot of times our patients are coming back for a follow-up, so we can touch base. The third group is like when they say, huh, something feels different, something feels better. Dr. Lynn and I, she had a patient once where this patient could not turn. She couldn't, she would be walking and she could not turn the corner because she would get super dizzy. The binasals were put on, and she would have to walk with her husband around, especially around corners. She could turn the corners, no problem. She was like, wow, I can actually do this. I've had patients say, my brain feels softer. I don't feel like my brain is as active or like hyperactive right now. I've had patients say, just actually yesterday, we had one say, oh, I don't know how this can be possible, but now when I'm moving my eyes side to side, I don't feel as dizzy. So we don't do it on every single patient. We do it based on our chief, when we're having our discussion with our patients of like, what are your symptoms? What are your concerns? We try it if we think it's appropriate. And it's that huh group that says, huh, I don't know how this is possible, or what kind of voodoo. I had one patient be like, I don't know what kind of voodoo you're doing here.
Right.
It's just tape. There's no voodoo. And so, yeah,
Yeah, awesome, man.
Yeah.
So it's great that sensory overload.
sensory overload,
So
exactly.
yeah, great. Thank you. Appreciate it.
That's
Yeah.
so funny that you mentioned voodoo, because I was just gonna say some people will be like, okay, well, where's the hard science about
Yeah.
this?
Yeah.
And in fact, there were studies where they did electrodiagnostic tests
Mhm.
with patients with traumatic brain injury and those who didn't have a history of traumatic brain injury using these binasal occlusion.
Yeah.
And if you have someone who hasn't had a traumatic brain injury and you cut out some of their vision, the brain response will be less.
Mhm.
But what they found was patients who had traumatic brain injury and had that visual motion sensitivity,
Mhm.
when they cut out some of that overlapping central vision, they actually had better responses. And it's because they were able to utilize the vision more. So even though we don't know the exact mechanisms of exactly why it happens, there is evidence to show that it does work specifically for the TBI population.
Mhm.
But one thing I say all the time is that, and I'm sure you've all heard it, is that every brain injury is different. So we'll have patients where they had what they would have thought was a very mild injury, like they just bumped their head on something, and then they have all of these really extensive and severe symptoms. And then I'll have patients who were at the VA and they have this huge military list of injuries that they've had. And then they'll just have light sensitivity, or they'll have a little bit of something, but not something as extreme. So everyone
It's different.
experiences
Yeah.
their brain injury differently, and everyone recovers differently.
Yeah.
And likewise, everyone responds to these treatments differently. So it's definitely not one size fits all. Like we said, we'll try a thing. We'll try a tint, or we'll try a filter, and I'll tell the patients, like, this works for some patients.
Yeah.
Let's see if it works for you. And if it doesn't, that's okay. We'll try something else. Yeah. I saw a comment there about some of the lenses, like the specifically FL41
There,
type
yeah,
lens,
I think,
like
yeah.
the Theraspecs.
Yeah.
That's also something that we do try for patients.
Yeah.
And some patients love it, and some patients put it on and they're like, nah, doesn't really do anything for me. And that's okay. If it doesn't do anything for you, you don't have to use it.
The other thing is the challenging part is these tinted lenses are also made differently. So like you can come to our clinic and we might recommend like an FL41 or a pinkish tint, if you need it. But then you can go to another place and they'll say, oh, we have an FL41 or like a pink tint, but it will look completely different. So that's the other challenging part. And so, but at least those tools are available, but that's another thing. Like the tint color may not work in our office, but it might work in another office because it's slightly different.
Yeah, and another thing you brought up on the tints is the tints, like the FL47, for example, is like the darker tint.
Yeah.
But then, as you were saying earlier, that you should over time be sort of tapering off and just titrating down the level of tint. Otherwise, you kind of get to a deconditioning process.
Correct. And so we've had patients when I started working with our optical lab, this is when I was in the East Coast, we were actually able to titrate or bleach the tint over time. And what I've been noticing since I've been on the West Coast, and I love that because I'm like, well, East Coast, West Coast, slightly different. But what I've been noticing here is like patients will actually start to self-titrate, which is awesome. So like we'll give them a tinted lens and then they'll come in, the first few weeks, they're like, yeah, I'm wearing it. A few weeks later, they'll say, hey, I'm only using it on the computer now. I'm like, that's awesome. And then a few weeks later, they're like, oh, I actually just took it off. I didn't even realize I need to wear them anymore. And I'm like, that's great. Now I don't have to deal with my optical. So it's like nice. So patients will also start to self-titrate, which is very telling of the progress that they're making throughout their therapy programs, which is nice.
Oh, and so in that self-titration, it's not only just titrating down with the level of tint, but
Intensity,
it's
how much
also
you're using it. Yeah, that's exactly it. So that's another way to self-titrate.
okay.
Yeah.
Awesome.
Yeah, and so if you're working with a very good optical lab, they should be able to customize those tints. Like if you go online, some of these companies, they just have one darkness, like the Theraspecs, I think, has two darknesses.
Yeah.
But we can, if we work with a custom lab, we can make it a specific like density for the patient. Yeah. Let's see. I just wanted to mention this briefly too. Driving is oftentimes a question that comes up a lot.
Yeah.
Yeah. People always
Yes.
ask, am I safe to
Yeah.
go back to driving?
Yeah.
And we're just seeing our patients in our office, right? And driving's not just vision, it's your leg strength, it's your arm strength, it's your reaction speed. So we'll work very closely with groups like the St. Jude Driver Assessment Program.
Yeah.
Yeah, to do that assessment. And we just got a report back on a patient, and we're so excited because we did the full assessment, and it looks like with some additional training and with very specific recommendations, this patient who had a stroke and who had a hemianopia is going to be able to get back to driving. So she's going to do the driving program, and then once she's done with that, we can help her fill out that DMV form so that she can go ahead and like reinstate her license.
We had a question
Yeah,
right here.
well, my really serious injury was when while I was driving my car, I got hit by an 18-wheeler, and I want to learn to drive again. And I wanted to do it for a decade, but I almost died a decade ago. So I want to learn. I had to learn how to walk again, So I do honestly want to drive again.
Yeah.
I would get to work, which I was working when I hurt. So I was
Right.
able to work again, like driving wise.
Yeah.
Yeah.
So I just really want to do that.
Yeah.
So from what I hear, your question there specifically is like, so in being able to connect to, let's say, your clinic, would, in addition to the help from the CRW for the driving to help learn how to drive, the glasses would help him learn to drive again by accommodating some of the visual weaknesses that is that right?
So when we think about going back to driving, there's a couple things we'll check. Number one, is your vision at a level where in your state or nationally you are allowed to drive,
Okay.
right? Because there is actually a cutoff,
Yeah.
right?
Yeah.
Like there's a point at which the state is like, okay, you're not allowed to drive at all, right? And in fact, that cutoff is legal blindness. So if your vision is worse than 2200,
Yeah.
with your correction, with the best correction, the DMV is not even going to let you take the driving test. But if your vision's better than 2200, and I would say that's a majority of patients with brain injury, then we'll say, okay, this is what it exactly is. Oftentimes the DMV, if your vision is very good, and it completely varies state to state, but in California, if your vision's kind of better than 2040-ish, you'll just go to do the regular screener in California, and they'll just push you through the regular process. If your vision's kind of between that 2040-ish and that 2200 legal blindness, they will say, oh, we want this form filled out. So any eye specialist can fill out this form, but we like to take our time to really make sure we get all of the details put into that form. And then for patients who are unsure about the safety, then we'll do that additional driver assessment program.
Right.
And then if we need to come back and adjust the form, or if you do have pretty good glasses, but if we can get an extra line of vision or an extra 2 lines of vision with updated glasses, we'll get the updated glasses. If it's better with the tint while you're driving, we'll throw on the tint. Right, we'll like put on everything we can to maximize, like you said, to maximize the vision as much as possible.
Yeah.
And that could include kind of those prism lenses. We do have patients with hemianopia, side vision loss, where they use prism glasses to help with their scanning and their side vision.
About those. When I'm reading, I have to like adjust the distance, like right here, move right here. Keep doing it. It's like I have it in my phone. I want new glasses. And I have that room wide. So it's because of that. But I like the way you describe it too, because very, very, very interested in driving.
Yeah.
Yes.
It's like really, I'm 44.
Yeah.
What you also mentioned about having to like adjust.
Yeah.
I see that a lot.
Yeah.
Yeah.
I know oftentimes before head injury, patients will say, oh, I did fine with progressive lenses. I had one pair of glasses that did everything for me, and that was just so easy. But afterwards, sometimes you need more help. So it's not uncommon for patients to have multiple specialized glasses, like a full pair for driving and walking, a full pair for reading. So you're not having to try to find that sweet spot on your progressive lenses. The whole lens is for your reading. And then what we'll do is we'll customize it for how far you want to read. So if you say, I like to hold my phone this far from my face, we'll measure that and we'll get the glasses for that distance.
The glasses, can you do like bifocals? You do like to make one glass like see further and closer?
Yeah, so we can do bifocals, so we can say, there's a distance, and then here is your near for exactly the distance that you want.
Okay.
Perfect. So there's lots of tools to help get you to your goal.
Yes, there are.
Well, scaffolding.
Yeah, no, very like going up slowly surely. Yeah. Okay.
Slowly but surely.
that's my
Absolutely.
phrase, you know.
Yeah. And then
Yeah.
if patients don't get to a point where they feel comfortable driving again, of course we're in California, so it's really hard to get around with public transportation, but there are services like Access Transportation where we'll help the patients make sure that they know how to sign up for that so that they can get around in a place where maybe the bus is not the most convenient. Yeah. Any
Thank
other
you.
questions?
Perfect. Yeah, and we had a couple of questions. So one was about the FL47, which I think we got to.
And then there's another one, right?
I think there's one about fleet.
The blinking of lights.
Yeah, and there is a question regarding some of the considerations regarding excessive blinking.
Yeah.
Is that a visual, potentially a visual thing?
It could be. I think for blinking like that, I would probably want to check multiple things. One of the things I want to check for is dry eye. We know that patients have more symptoms of dry eye after a brain injury. And that could be one reason we're blinking more. We'd also want to check the eyelid health, eyelashes health, and all of that because that's associated. And then I also wonder if it's like pupil size related or corneal sensitivity related. So yeah, definitely worth mentioning to your eye care provider and then having them kind of run through the options to see if there is something that can help. You want to say anything?
I
more about
agree with Dr. Lin, 100%. I agree with that.
Perfect. Other question? Oh yeah, Eddie. You had a question? Yes.
Thank you